Do you want to know more about male pattern baldness? Then you probably need to see this video. I'm Dr. Mazhar Hussain. Please do subscribe to our YouTube channel and click the notification bell so that you're updated with our videos. Male pattern baldness is also called androgenetic alopecia or androgenic alopecia. In women, it's also seen, and it's called female pattern baldness in women. And it affects, for women, it affects more than 50% of women, postmenopausal women. There are even studies that say up to 60-70%. But we're going to talk about the male pattern version. So there's a genetic component to it, and it's the most common form of hair loss in men and in women. And for white Caucasian men, you could say that it roughly follows the decade that people are in. So 20% of white Caucasian men in their 20s would be suffering from male pattern baldness, and 50% of men in their 50s would be suffering from male pattern baldness. And the frequency do vary according to the race. So it's not like we can just copy paste the numbers from one ethnic group to another. There are a number of classification systems that have been proposed. The most common is probably Hamilton-Norwood scale, and Ludwig scale is used for female pattern baldness. Anyway, if you look at this, we have the very mild version with slight receding hairline in the temples area. That's Norwood 1. And the most extreme with Norwood 7, where we have hair loss on the front top, crown, and even the side and the lateral hump has come down, and the crown is quite big. So it's quite a dramatic hair loss in this version. This is milder, and of course many men are from 2, 3, 4, maybe 5. So the cause of it is androgens. It's male hormones that can be seen both in men and women. The testosterone is produced in the testicles, and it's converted into something called dihydrotestosterone. The hair follicles in the front top and the crown of the scalp, in the vertex area, they can be sensitive to varying degrees. They can be sensitive to these dihydrotestosterones, and it can then lead to hair loss. Depending on how sensitive they are, the hair loss may affect some follicles sooner, and others it may affect later. There's a genetic component to it, and we see hair loss running in families, but it's not a one-to-one. Inheritance is not like if your father had hair loss, you have to have the same hair loss in the same way to the same degree. You can also inherit from your mom's side and your dad's side, and there are multiple genes involved. However, if you have a first degree or second degree relative with male pattern baldness, then you're more likely to have it yourself. Anyway, there can be, although it's a strong genetic component, there is something we have to remember. Even if you have some familiar predisposition to get this kind of condition, if you live a very unhealthy life, or if you're anemic, malnutrition, severe weight loss, or severe weight gain in a short span of time, if you're stressed, smoking, alcohol, and so on, this may actually speed up your hair loss. It could be if you were living a very healthy life, no physical, mental stress. It could be you could keep the hair going for maybe till you're 35. And if you're very stressed, can't sleep properly, your nutrition is not good, it could be you lose the hair, say the same degree of hair loss at 28, for instance. So it does really matter whether or not how you treat your body. Diagnosis is usually from the history of the patient, the clinical presentation. We rarely need to take any blood tests. We may still take them in some cases to rule out any other contribution from other factors. And we may need to find out if there are any thyroid issues, if we, from the history, suspect there could be some other contributory factors. When we talk about the treatment, first of all, we need to look into treating any underlying disorder. Once that is sorted and we have looked into that, we can also use something called minoxidil, usually 5% minoxidil. It can cause some, it can have some side effects, irritation and itching. It can lead to dry scalp and facial hair. We may also use ketoconazole if there's a lot of dandruff, or if we maybe suspect there's on top of the male pattern baldness, if we suspect there's any fungal infection, we may need to treat that also. We do have two medicines that are quite good for hair loss. If we do look at only the hair loss treatment, but it also comes with a number of side effects. It can cause impotence, decreased sex drive, and it can cause nipple pain and testicular pain. Some patients may have more suicidal thoughts and psychological problems. I personally used to recommend this, but as we get more and more information about the side effects of finasteride and dutasteride, I'm much more reluctant than I used to be. I'm not ruling out completely recommending it for specific patients, but generally I would rather not. Finasteride and dutasteride are not approved for women, but it can be used, and there can be situations where we need to consider this. We have platelet-rich plasma. It requires maintenance. It's not like you restore your hair and then it stays there for life. You still have the predisposition to actually have hair loss, so you need to maintain that. There's no established protocol. There's no consensus on what is the right protocol, and the amount and concentration may vary from clinic to clinic. Many clinics would be using 10 or maybe even 20 mils of whole blood to make PRP from. We usually want to go towards 60 to 80 mils for PRP treatment. Stem cell therapy is relatively new. I've had it myself. You've had other patients with this treatment. Again, we don't have a protocol established, the best optimum protocol. We don't have any consensus of that. We don't know exactly, should we be drawing 10 mils of fat cells and make stem cells from that? Should we draw 40 mils and use that to create and isolate the stem cells? So there's a discussion about what the right protocol should be in case of stem cell therapy for male pattern baldness. There are a number of more experimental treatments, such as omega-3 fatty acids. The laser comb and the laser helmet can be considered, and maybe it also has some effect. The jury is still out on that. I know some doctors may disagree with me, but it may be we probably need more data before we can say something more clearly about the use of this. The same goes with the LED light. Of course, the hair transplantation is an option that should not be discarded. It's quite a good option. The better the donor area, the better results we can achieve. And we need to take into account the age, the sex, and the hair loss pattern, the family history. We have to avoid over-harvesting, and it's of course very important that we have natural results. That's the most important thing. But if the patient has a good donor area, very often I would be more inclined to recommend hair transplantation, also because it gives a permanent result, and in many cases, in most cases, a lifelong result. So there is no maintenance required. It has a huge advantage over the other options, but there can be patients that simply don't have the donor area to do a hair transplantation, or the donor area may be insufficient for the results that the patient want, and we might need to combine hair transplantation with medical treatment options. So this concludes our video on male pattern baldness. I'm Dr. Mazhar Hussain. Please subscribe to our YouTube channel and click the notification bell so that you're updated with our videos. Thank you.